Welcome to this presentation on meningitis. Meningitis can be classified as acute, subacute, or chronic, and more than likely is caused by a bacteria, but it can be viral in nature. For this presentation, I'm going to focus on acute meningitis caused by a bacteria. Acute bacterial meningitis occurs due to a sudden inflammation of all of the meningeal layers of the brain. Common bacteria that cause an acute episode of meningitis are listed on this slide. Luckily, there are vaccines that can help to prevent the occurrence. For H. influenza, the HIB vaccine is administered to infants beginning around 2 months of age and continues with a series of doses until about 1 to 1.5 or so years of age. There is a vaccine available to college students or others who live in large group settings that can be administered to combat Neisseria meningitidis. The pneumococcal vaccine is administered to individuals at high risk of developing pneumonia. Pneumonia that progresses to a blood-borne infection is one risk factor for developing bacterial meningitis. Transmission is through direct contact with respiratory and throat secretions. This includes saliva. For the most part, transmission occurs through close contact. Therefore, some at-risk individuals includes those exposed to large, tight groups of people, such as in daycares, prisons, college dormitories, and military bases. The incubation period is very short at 1 to 10 days, so symptoms can become apparent fairly quickly after exposure. Other risk factors include presence of an infection close to the brain, such as otitis media, sinusitis, or a tooth infection, for instance. Neurologic surgery, especially one that penetrated the dura, is another risk factor. Therefore, a basilar skull fracture also has the potential to penetrate the meninges and can be a culprit. IV drug use, due to the potential of using infected needles that become blood-borne infections, and any condition that puts the patient at risk for being immunocompromised. This can also include the vulnerable age groups, such as the very young and the very old. Therefore, it is important to seek prompt treatment if infections are suspected. If caring for a patient with penetrating head trauma or post-op neurologic surgery, prevention of an infection is a priority. The signs and symptoms occur very quickly, and if not immediately addressed, can progress to shock and death. Flu-like symptoms develop initially, such as a headache, fever, chills, myalgias, and overall malaise. The symptoms, though, progress to altered mental status and vomiting, early signs of increased intracranial pressure. Inflammation of the meninges produce a stiff neck, also called nuchal rigidity, photophobia, and possibly hallucinations. The headache becomes much more severe. A very telling sign is the petechial rash that can develop, followed by purpura. Left untreated, bacterial meningitis results in shock with concomitant DIC, increased intracranial pressure, and ultimately a coma. With any suspicion of meningitis, the patient will immediately be placed in standard and droplet isolation. Typically, these precautions need to remain in place for at least 24 hours post-initiation of appropriate antibiotic therapy. Prior to any antibiotic therapy, the patient will have blood, urine, nose, throat, and sputum cultures at minimum. Patients and families will be asked for a list of people that had close contact with the infected patient, as they need to be prophylactically treated with antibiotics once meningitis has been positively identified. A CBC with differential will also help to identify the presence of an infection. Another diagnostic tool used to diagnose meningitis is a lumbar puncture. Typically, patients are placed on their sides for the healthcare provider to best identify the vertebral landmarks, but the patient can also have one performed while they are sitting. Needle placement is below the level of the spinal cord, which typically ends around L2. You can see in this picture, the needle is being inserted at around the level of L4, L5 on the vertebral column. CSF fluid obtained by the tap is normally clear and without any color. You can see by this example that the cerebral spinal fluid is cloudy and slightly purulent. A positive CSF culture for meningitis will have increased white blood cells, low glucose levels, and increased protein levels. The culture will also help to identify the culprit bacteria. A CT or MRI scan may be done to see the extent of increased intracranial pressure. There are what is considered classic presentations for meningitis, but truly in reality, they rarely occur. But when they do occur, they are telltale assessment tools that assist with the diagnosis. With a positive Kernig sign, the healthcare provider will flex the hip and the knee. As an attempt is made to extend the knee, the patient will complain of pain. With a positive Brudzinski sign, the healthcare provider will flex the patient's neck. This will also cause excruciating pain, and the knees will independently flex. These signs indicate meningeal irritation. There are some clearly identified goals for patients diagnosed with bacterial meningitis. As I have already discussed, isolation of the patient will occur immediately upon suspicion that the patient has meningitis. Those exposed to this patient will also need to be identified and treated. The same treatment goals for any patient suffering from increased intracranial pressure apply here also. Due to the photophobia, a dark room is encouraged, along with keeping the environment around the patient very quiet. Cooling blankets and acetaminophen will be used to keep the body temperature as normal as possible. The head of the bed will be elevated, at minimum to a 30-degree angle or higher, and the patient will be kept on bed rest until the intracranial pressure normalizes. Observe for signs or symptoms of seizures and treat accordingly. Antibiotics are started as quickly as possible, usually broad spectrum initially, followed by culture-specific sensitive antibiotics, usually in the penicillin or cephalosporin groups. If vomiting has compromised electrolyte levels, these need to be corrected. Hydrate the patient to normovolemia, but not enough to increase ICP. Remember that isotonic or hypertonic fluids are used with evidence of increased intracranial pressure. Short-acting analgesics are used so as not to blunt the neurological status of the patient. If the headache that results from meningitis can be adequately treated with acetaminophen or NSAIDs, then they are the clear choice. Steroids may also be utilized to reduce cerebral inflammation. This is the conclusion of this presentation. Should you have any questions, please don't hesitate to access your instructor for the course. Thanks for listening.